All right, we're going to get started. So thanks for joining us today for another webinar in Diabetes Canada's 2020 webinar series. Today's webinar is on influenza, diabetes, and now COVID-19. An important topic as we're in flu season towards the end of the year. And we have a great speaker today. Daniel Burton is joining us to give this presentation. So I just wanted to make a quick note. We'll just advance one slide. Today's presentation is supported by Sanofi Pasteur. So we appreciate their support in making today's webinar happen. So without further ado, I'll pass it over to Daniel.
Awesome. Thank you, Grace. All right. Welcome, everybody. Thank you very much for joining me today. As Grace mentioned, we'll be talking about influenza, diabetes, and the current hashtag COVID-19 situation. Really hoping to kind of just give you guys more of a high-level view at some of the evidence and more focusing on what specifically you need to know in terms of coming into the current flu season and how to mitigate, how to manage, and what kind of things we're looking at. For all my contact info, I'm basically on all the social media channels, and you can find my email and website there. So feel free to reach out if you have any questions beyond this. My area of expertise primarily is in obesity, but diabetes is a very close second to that. And happy to answer any kind of questions, and I'm quite frequent and quite do a lot on social media and stuff like that. So if you have something there that you think others would benefit from, please feel free to pass it along. So I kind of want to just start by lightening it up a little bit here. It's always a little bit challenging with these webinar-based talks, and for the few that I've done, I like to tell a few jokes, and it's fortunately enough that I think my own jokes are funny enough that I have no problem laughing at them. But it's always nice when you can get a read of the room and you put a joke out there and other people are similarly reacting or not. But I can also say that I am missing the conferences, the bad coffee, the pastries, and in some cases I might mention the bit of a hangover from the networking the night before and stuff like that as well. So thank you very much that you're all joining us here for this webinar. It is a pleasure to provide some of my expertise anyways in this area. So just a few things, housekeeping out of the way here. Here's my disclosures. I have done some consulting work and such with Novo Nordisk. I have received grant funding for a research study that we're doing out here in Alberta. I'm a board representative for the Pharmacy Examination Board of Canada, and I am the co-president of the Obesity Canada Calgary chapter. As well, I'm receiving a speaker's fee from Diabetes Canada for this learning activity. And again, Sanofi is providing financial support for this learning activity. So here's our learning objectives. Our first one here, I want to just kind of go over the influenza vaccination guidelines. It's pretty straightforward, and I find this topic a little bit, it's kind of seems like a no-brainer, but certainly I think there's a lot that we can kind of look at in terms of the evidence, and that's kind of what I also want to outline some of that for you as well. Just because there is some controversies and stuff within the evidence and some of the other talking points, and some stuff to be mindful of and be thinking about as you're kind of, especially coming up into this year and you're talking to patients. And then finally exploring a little bit around the COVID-19 situation in diabetes and what that means for our whole influenza and flu season and such. All right. So first and foremost, we know diabetes is a problem. It is a growing problem, and it's being considered one of the largest global health emergencies of the 21st century. So, I mean, chronic diseases in general are growing, but diabetes certainly is becoming more and more of an increasing concern. And yeah, this is for Alberta alone. We're expecting a 10% increase by 2028. So definitely a large scale problem and something that we need to be looking a little bit more closely at and doing what we can to mitigate and manage it for sure. All right, so let's get that. Now, influenza. Just want to kind of brief overview on the flu itself. Obviously, it's a respiratory infection. The two primary viruses that we're looking at are influenza A and influenza B. Obviously, it's a seasonal epidemic for us here in Canada, generally September, October-ish to maybe April, May, maybe June sometimes, depending on what part of Canada you're in. Main symptoms. I always like talking this with patients because, there's always the question of, well, is it a flu? Is it the cold? What have you? And my biggest thing for patients is you will know when you have the flu. You likely will not be able to go to work. You will feel like you're hit by a bus, and it'll be very abrupt. So fever, cough, muscle aches and pains. Fever is a big distinguishing component between a cold and the flu itself. Some other common symptoms, which may or may not be seen with a cold as well: headache, chills, loss of appetite, fatigue, and sore throat. And sometimes in children, you might see more GI related side effects. And obviously, with severe complications, pneumonia and death are kind of the two big ones, as influenza or respiratory infection can become pneumonia based and certainly can lead to death in the most dire circumstances. And again, like diabetes, this is a significant burden on the Canadian healthcare system. So looking at anywhere from 1,200 to hospitalizations and 3,500 deaths per year. So again, another big issue and another big health concern happens every year. We need to look at how we can mitigate and manage it, and obviously take the burden off the healthcare system. Diabetes and influenza. Obviously, a big problem. People with diabetes are at a high risk of complications, everything from hospitalizations to death. And generally, a lot of it is, they have multiple comorbid conditions. So maybe COPD, hypertension, renal disease, all of which can be exacerbated by an influenza infection. Some of the more recent literature, which is very fascinating, is, as we know, the people with diabetes are at an increased risk of ischemic events, so heart attacks, strokes, that sort of thing. And when they get an influenza infection, for about 7 days post the infection, they're at a 6 times increased risk of having an MI or a stroke. And it's thought to be because of an abrupt increase in inflammation, ultimately leads to that increased risk of them potentially having a heart attack or a stroke. So obviously that is a big major concern, and that is quite a jump in the risk of ischemic events. So definitely something that we want to be mitigating and managing. And if we can provide them something that proactively will prevent them from getting influenza to begin with, certainly something we want to look at. As well, I'm sure some of you have had to manage a patient that has been sick, or at least have heard the stories of a patient that's been sick, and they were sick for a week and they suddenly come into your office and they're like, yeah, my blood sugars were way out of whack, they were sky high, or they were up and down, or what have you. Again, acute illness causes that inflammatory response and certainly can make their blood sugar control a little bit more challenging during that period of time. As always, we want them probably to run a little bit on the higher side, but obviously not too high, depending on the patient and such like that. And then that's also where the medication management comes in, such as the 6-day guideline. So if they can't take anything by mouth, stopping things like metformin and such, and ensuring that they're still taking their insulin and stuff like that. So it's a whole lot of complicated issues that can kind of all be encompassing. It's not just necessarily the hospitalizations and death. Our community dwelling patients that maybe don't reach that point still need to be properly managed, properly counseled, and we need to still be looking after them in that respect. And so some of the other reasons why people with diabetes are a little bit more at risk of developing influenza and having complications is because of the abnormal glucose metabolism. So having diabetes itself seems to cause a bit of a dysfunction in terms of our white blood cells. So affects the ability of our white blood cells to collect up and swallow foreign invaders. Our chemotaxis system gets thrown off, so the chemical signaling between cells and telling, hey, there's an infection here or not an infection here or what have you, that gets a little bit of disrupted. And then also our white blood cells' ability to adhere and to essentially fight off invading pathogens and stuff like that. So all certainly things that can kind of compound and worsen the overall the aspect of the influenza infection and such. The vaccine itself. So every year, the World Health Organization will put out their recommendation, and basically this is their best kick at the can to say what 3 strains they think are going to become prevalent in the Northern Hemisphere. So they always put a recommendation out for influenza, 2 influenza A strains and an influenza B strain. Influenza A tends to be the more prevalent, and they say the more harmful in terms of complications and stuff like that. So that's why we tend to have more focus on the influenza A strains. Influenza B, yeah, maybe not as much, maybe not as virulent, that sort of thing, but still something that definitely can happen. Again, it's kind of our best kick at the can as for which one is going to be prevalent in the communities and such. Most drug manufacturers will look at putting together a quadrivalent vaccine. So they actually add an extra influenza B strain to their vaccine mixtures. The reason for that is that they're trying to essentially, hedge their bets and put another strain in there that may potentially be out in the community and such, and essentially just trying to provide that extra level of protection for something that may potentially be coming around. Now, I'll be very curious to see with COVID and everything like that, how this all plays out. We have, although travel is increasing, but there's less travel that's happening between countries. What we know from the influenza season last year, that essentially when we all went on lockdown, we basically snuffed out the entire flu season altogether. Cases just dropped right off, and that social distancing, washing your hands, all that kind of stuff is very effective measures for preventing the spread of the flu. And fortunately for the flu, it spreads a whole lot. It takes a whole lot. It's a lot more for it to spread compared to the COVID virus. So very, very interesting. So I'm curious to see, with some of the measures and mitigations that are in place at the moment, how that's actually going to affect our flu season upcoming this year. Now, the National Advisory Committee on Immunization, NACI, they create the recommendations for Canada from the WHO guidelines, and they look at a variety of different things and basically tell manufacturers, all right, this is kind of what we're thinking. Go ahead and make your vaccines based on these recommendations. And then the manufacturers will make both quad and trivalent formulations, all depending. And primarily we have inactivated or attenuated strains here, but there is one live attenuated vaccine available in Canada. If you had gotten this email, this actually came out from the Canadian Healthcare Network just, I think it was like last week or maybe the week before it. But this is a beautiful little table here. Basically shows all the different flu vaccines that are available in Canada, and then shows which ones are being currently publicly funded. So you can see it varies province to province, who's covering what, etc. Excuse me. And so it really is quite a bit of variability there. Primarily, you guys will probably see ones, the Fluzone, the quadrivalent from Sanofi. That's definitely the one that I've seen. I've seen the Afluria Tetra as well, as I'm based in Alberta. So that one's also been another one that's been around here. And I've seen the high dose Fluzone as well. So the other one made by Sanofi. So those are primarily, depending on where you're at, you're going to see any kind of variation of that in that respect. And then some of you might see the flu mist, which is the live attenuated vaccine, and primarily for the pediatric population, depending on where you're located in the country. So the big question, should we vaccinate? So here we'll kind of take a bit of a dive into some of the evidence and just have some of the few talking points, and certainly some good points, hopefully, that you can take away and discuss with patients as the questions and stuff come up. But looking at the effectiveness of the influenza vaccination in elderly diabetic patients, a retrospective cohort study. Now, I will give a quick caveat here that most of the research that's done in this area is primarily observational data, and in particular retrospective. So the researchers basically go to a health system and say, hey, can we access your records? And we want to look back on the last 2, 5, 10 years, whatever. And they have to look through and kind of find people that got the vaccine or didn't, and then also look for, usually they go by the ICD codes and what they're diagnosed with. So if there was a diagnosis for diabetes or something like that, try to match that information up, and then they can punch it out and say, look at, were they hospitalized at any point in time, yay or nay, and then trying to adjust and mitigate for confounding variables and stuff like that. So observational designs and stuff like that can be a bit challenging in that respect. Oh, sorry, you guys aren't able to hear me very well.
Yeah, Dan, it's a bit hard to hear you at the moment. Sometimes it's quite clear, and then sometimes it just sounds like it drops out a little bit. I'm not sure if it's the headphones.
Okay, let's see here. Is that helping it at all? Me just kind of putting it up closer to my mouth?
That sounds pretty good. The last sentence you said there, that sounds pretty good.
Okay, so shoot a message there if you guys are having any problems. Hopefully this kind of will mitigate it for us here. But as I was saying, yeah, so some of the retrospective studies, there is obviously the limitations of the observational studies, but they can still be beneficial in helping us to ascertain whether the data is and what are the benefits of looking at things like influenza vaccination. So particularly looking at this study was a retrospective study. Now this one looked at the databases from the Taiwan's National Health Insurance Program. So might not be necessarily applicable to here in Canada, but nonetheless, they looked at the flu seasons from 2001, 2009. Particularly, they looked at patients that were still terrible in and out. Let me try something here. Hang on a second. All right, does that sound any better?
That sounds great.
Sounds great? Okay.
Yeah.
All right, so here's the Wang IK, as I was saying, elderly patients greater than 65 years old with diabetes. They were, basically they showed that the influenza vaccination was beneficial for these guys, reduced the risk of morbidity, hospitalization, ICU admissions, and mortality. So definitely a point for showing that the vaccine is beneficial in this demographic, in this population from the season of 2001 to 2009. Now, why part of the couple of things that I want to just cover on as with the observational trials, partly why we use them is, again, it's very difficult to do, say, a randomized controlled trial with these populations and these demographics, big in part because it's an ethical concern. We can't really, deny someone the influenza vaccination. We figure that there is a pretty good chance that it's going to have some benefit. So we do more observational trials to kind of ascertain things and determine if it is effective or not versus doing a randomized controlled trial. As well, randomized controlled trials, this would be challenging looking at it over season to season because the vaccine changes and such. So to get the full gambit of it, we really need to look at multiple seasons to see what kind of protection and effectiveness we are getting from the vaccines. So some stuff to kind of keep in mind is further why we use these observational type trials. Now, my next slide here. Looking at the Cochrane Library, so these guys are really interesting. They're kind of the, I guess you could say, kind of the poster child. They're really good at really ascertaining and going through a variety of studies and ascertaining how much bias is there and putting them into good quality systematic reviews, and to really punch out what kind of data and information that they're able to pull from multiple studies and multiple sources. So kind of a gold standard. However, one point that I do find about them is that they can be a little bit on the purist side. So it's either very black and white in terms of their reviewing of the evidence. They don't look so much at the gray side of things. And that's certainly what becomes apparent in their research aspect of things here. And as you'll kind of see in their conclusions here, what they looked at is they accounted for observational trials in kind of a historical sense, but really they said it didn't affect their opinions on the forefront of things. They're really big about looking at randomized controlled trials because that's their gold standard. That's their highest level of evidence that they think is the most effective and beneficial. But nonetheless, I think I wanted to kind of bring this up as this is also something that's often used for the public and what the public will kind of say, especially like the anti-vaxxer movements. Because these studies and research from the Cochrane Group is freely available online, this will be something that potentially comes up and is talked about by more layman people, and certainly something that you'll probably get questions about from what I found. But what they found nonetheless is by looking at 8 randomized controlled trials of elderly patients, so these patients didn't have diabetes, they did find that getting the influenza vaccine probably did lower their risk of getting influenza and also lowered their risk of influenza-like illness over the course of a single influenza season. So again, I think this kind of highlights a few of the problems with randomized controlled trials. It's looking at a single influenza season, and we also have some of the confounders of influenza-like illness. Now, one of the issues with the influenza-like illness is that it varies based on who's making the diagnosis and what the criteria are. Influenza-like illness, it's not confirmed by a lab that a patient has influenza. It's all based on their symptoms that they have. So that's going to vary obviously person to person, and the number of viruses and such that can cause influenza-like symptoms is quite variable and quite high. Nice thing is that they don't have enough information to really ascertain the fever and nausea. So one of the final points here is that they kind of make a statement that it provides no clear guidance for public health regarding safety, efficacy, or effectiveness of influenza vaccine for people older than the age of 65. So really kind of throws a wrench into a lot of the work that we do and some of the kind of outreach in terms of influenza vaccinations, and certainly is one point that people will bring up as a potential pushback in getting the influenza vaccine. However, you can kind of highlight some of the issues with these studies and such, is that once again, it's randomized controlled trial, it's a single flu season, and this one wasn't specific for diabetics, but elderly populations are still a high risk group nonetheless. But it's kind of just a counterpoint that I wanted to bring up, just as to stir the pot a little bit, if you will. This next one here, so this is looking at patients that have diabetes and are less than 65 years old. So working age adults with diabetes, their immune system should be a little bit more robust. We've removed kind of the elderly component, and it's more just their diabetes, which is their main risk factor potentially. Obviously, any other comorbidities they might have, but looking at a different demographic and different population. And also this one came from pulled data from Manitoba Health in particular. So the nice part about that is that obviously it's very applicable to our patients here in Canada, coming from Manitoba Health and such. And again, it was a retrospective population-based study. So they looked back at 2001 to 2008, and only patients that were 18 years of age or older and less than 65 and had diabetes. Again, what they found is that there was a reduced risk of pneumonia and influenza-related hospitalizations and all-cause hospitalizations as well in those patients that got the influenza vaccine. Now, a lot of people, when they report this study, they also leave out this last point here, which is that similar results were still seen outside of the influenza season. So when they looked at these patients during the summer months, for example, what they found is that they still saw this reduction in pneumonia and influenza-related hospitalizations and such. So it kind of brings into question of, is there another confounding variable that they didn't identify potentially in the data? There might be something else going on there. So it's kind of just something to keep in mind, that maybe the data around the influenza vaccine isn't as robust for the 18 to 65-year-old working populations with diabetes. So again, another counterpoint, something to think about, but nonetheless, I think from this study, we can take away that the influenza vaccine likely does provide some benefit in this regard. Now, the next one is another Cochrane review. This one, again, wasn't done with diabetics, but it was looking at that healthy adult population, so less than 65, they're working age adults, that sort of thing, and just seeing if the influenza vaccine is beneficial in randomized controlled trials. And again, we may have a small benefit. The evidence wasn't all that great from the studies that they pulled, but it does look like it does reduce your risk of influenza, and probably reduces your risk of influenza-like illness through vaccination. So does possibly have that benefit, absolutely. Again, the evidence isn't the greatest. It was randomized controlled trials, but we got a little bit more data around adverse events. So again, very minimal, so minimal risk and possibly a benefit. So always something I like to talk about is, there may be a small benefit, kind of tough to say, I would say, in the working population. I would say more so those with diabetes, but the risk overall is quite small. So it's kind of, if your risk is so small, what are we really risking by just getting the vaccine if we might get a possible benefit that comes out of it? Again, the same things. There were single influenza season, and this one wasn't specific for diabetics. Looking at safety. So I just wanted to touch on this one again, just because safety was a question that I've been getting. I did a flu clinic a couple of days ago, and I did about 120 shots, and lots of first-time people coming through. And of course, they wanted to know about the safety. I heard that vaccines cause autism and such like that. Kind of the standard questioning that comes about. So just wanted to review some of the stuff on safety in particular. This study did look at a number of different factors, including effectiveness of the seasonal influenza, and they did show that it was effective as well based on their systematic review. But looking at the safety component as well, in particular, there was only 2 trials that really looked at safety, but they found that only transient and non-severe reactions were reported in both groups. And primarily what they were seeing was local reactions. So, the sore shoulder, and, you're putting a needle into someone's muscle. Yes, they are going to get a sore shoulder. Very similar to, I've already got my flu shot and my shoulder was sore as well. So not really surprised by that. Definitely something that's going to be the case. The more systemic reactions, which certainly will happen. It's the flu-like symptoms, just your body ramping up an immune response really to the inactivated virus, but you certainly can get some of these symptoms. But they were also similar between the 2 groups, between the placebo and the non-influenza groups and the influenza groups and such. So safety-wise, it looks like it's pretty good overall and very, very minimal risk, if anything at all. And then this is just a final one, because we had talked about the increased risk of MIs and strokes being 6 times higher with people that have diabetes in the 7 days post having influenza infection. So this study was really nice in that they actually looked at the cardiovascular mortality risks and such. And what they found is that, yeah, getting the influenza vaccine does seem to reduce your risk of all-cause death, cardiovascular death, and death from an MI or a stroke. So obviously, there is a significant benefit that can be had there, and certainly something that we do want to continue to promote. And it makes sense. If you're preventing influenza in the beginning, you're hopefully going to prevent any of these other that increase in inflammation and reducing that patient's risk of developing the MI or stroke and such in that sense. So another great study just came from out in 2020 or in 2020. So it's fresh off the press, good quality and such. And yeah, it certainly gives us a little bit more information in that respect. There's also one other study that I didn't have a chance to fully review in detail and add in here, but Sanofi had passed it along, and it was looking at lab confirmed influenza cases. So that was actually where the lab they'd done a swab, and they had confirmed that a patient didn't just have influenza-like symptoms, they had confirmed influenza. And again, there was a benefit that was shown in terms of those that got the vaccine versus those that did not. Vaccination, the forgotten step. So I just kind of wanted to highlight this because I know I'm certainly guilty of it. And I'm sure many of my colleagues are, and I know many of the endocrinologists that I work with certainly are. And that is the whole vaccination, flu vaccine, Hep B, you name it, tends to be something that is often forgotten in our assessments as we do our diabetes workup. And I've actually had to change my workflow where my EMR actually sends me or provides a prompt for me to ask about their vaccination history and stuff like that. It's really great. It's a proactive measure. It's not as front of mind as, say, their diet, activity, and medications and such. But nonetheless, there's a huge benefit that can come from it. It's proactive in nature, and it can prevent other issues and problems. I also do some work in hepatitis B and hepatitis C and such. And so anything we can do to prevent those kinds of infections and damage to the liver certainly is going to be beneficial and have a lot of, just a lot of benefit for our patients. And I would highly recommend just trying to bring it more front of mind as just a simple, quick question that you can ask and can give you a lot of detail and certainly help your patients in a lot of ways without really realizing it per se. So, should we vaccinate? Basically, everybody and their dog is saying absolutely. The NACI guidelines, their 2020 to 2021 statement just came out, and they certainly are recommending it for everyone that's 6 months of age and older, and who obviously doesn't have any contraindications to the vaccine. In particular, and I find sometimes we do a good job of this, sometimes maybe not so much, we really need to focus on our high-risk individuals. So people that have diabetes, obesity, other comorbidities that puts them at that high risk of complications, as well as those that are capable of transmitting the influenza virus to those that are at higher risk. So healthcare workers, I'm always disappointed by the healthcare workers' rates of influenza vaccination, and we really should do a push to get those higher because we're essentially a vector between people, and we're generally healthy working individuals, and we just go person to person, and who knows how many people we can come in contact with and pass the virus along in. I think COVID has given us a good perspective on how easily that can happen, unit to unit and such. And, Yes, COVID is a different virus and spreads a little bit more quickly, but nonetheless, it shows that healthcare workers can be that major vector in that respect of it. Okay. Fading in and out. Okay, I'll just have to keep yelling at my mic here. I apologize for the audio issues, guys. I don't know exactly what's happening on my end of things. Can you comment on Gillian? You mean Guillain-Barré? Barré syndrome. So Guillain-Barré, well, I'll save that one to the end. We'll review that as I go at the end here, okay? But essentially, everyone is saying that, yes, we need to work on properly immunizing these high-risk groups and making sure that we're taking care of these people versus just everybody in general. But something to think about, and certainly where our area of focus should certainly be. The high-dose influenza vaccine. So I just want to make a quick note on this because I'm sure some of you are seeing it, particularly if you work in long-term care at all. This one was developed as a strategy to elicit a greater immune response. So what we know is that with the standard dose influenza vaccine, elderly populations tend not to develop quite as robust of immune response to it. They just don't have the immune capabilities. Their immune system is obviously not as good as the working age populations and such. And so the high dose influenza vaccine is kind of a strategy to help mitigate that, as well as adding adjuvants. So that's things that they add on to the various viruses to ramp up an immune response. All of this is in an effort to try and, again, make the influenza vaccine more effective in this population. What they have found is that, yeah, it is beneficial. It does elicit a greater immune response, and it does seem to reduce the risk of complications, so hospitalizations and such like that. As well, the safety profile is relatively comparable. I mean, you're putting in more of the virus inside of your body. So yes, you are going to probably get more of an immune response. And as such, you're going to get kind of more of those flu-like symptoms that can sometimes happen. And some of those flu-like symptoms obviously are, yeah, the runny nose, sore throat, headache, that sort of thing. But again, they should be mild in general, and they should go away after a day or two. So definitely beneficial. And I'm sure some of you are seeing it. It is available across the country at the moment. And particularly in those patients that are greater than 65 and in long-term care. Hashtag COVID-19. So briefly want to just touch on this and some of my learnings that I've had thus far in the clinics that I've worked out of. The biggest problem with COVID, obviously, is that compared to the cold, compared to the flu in particular, all very much seem the same. There isn't really many differentiating factors in terms of the symptomology. COVID does have a few weird and interesting symptoms that can present, including the loss of smell and taste and such. But for the most part, if you ask a patient about some of these symptoms, it's going to present very much sounding like the flu, and in some cases sounding like a cold. So very tough to distinguish between the various components of it. And if a patient is presenting with this, we should be looking at getting them a COVID test. I know in Alberta, we just shut down the asymptomatic COVID testing at this point in time, just to allow the labs and stuff to catch up on all their testing measures and metrics in that sense. So it is posing an extra challenge, but if someone is symptomatic, they should look into getting the COVID-19 test and being monitored. One of the biggest things that we are finding between COVID-19 and influenza is that COVID-19, it's usually day 7 when you start to present with symptoms. So everyone on this webinar right now, 7 days ago, you could have been exposed to COVID, and now would be the day you would just be starting to potentially show some symptoms of it. So there is quite a lag in it ramping up in your system and causing symptoms. And during that entire time, you could be infectious at that point in time as well. So if we're supposed to keep social distancing, if we're supposed to be mindful of COVID, should we even still have our flu seasons and our flu clinics and stuff? NACI and everyone else is still very much recommending it. The idea that we're trying to go for here is, once again, reducing the burden on the healthcare system. If we can be proactive and provide something that's going to prevent our healthcare system from getting overwhelmed, then we definitely want to do it. In particular, again, our high-risk patients are just as much risk with COVID as they are with the flu. So we, again, want to be protecting those populations and really just kind of taking one more worry off of their plate and better managing the health of those individuals. However, our focus really needs to be on both protecting the patients and the healthcare providers that are potentially running or doing any of these influenza clinics. Biggest precautions you need to look at, reduce the crowding. So holding multiple smaller clinics, looking at things opportunistically. So if you work in a different clinic or just a general GP's office or something like that, and the patient's there, you have the flu vaccine, might as well give them the vaccine, just get it done, get it out of the way. Then they don't have to worry about going somewhere else and being further exposed. Appointments is a really big thing. Alternate models, there's pharmacies across the country are currently doing it. There are some provinces that are looking at paramedics, and even paramedics as they pick somebody up, giving them the flu vaccine if it's indicated. Flu clinics potentially outside. It sure as hell ain't happening in Calgary right now, but is another potential. If it's still nice enough for that, you could maybe set up a little tent and do something outside. Just different alternatives and different ideas, as well as trying to maybe do on-site immunization clinics. So rather than having people come somewhere where there's going to be a whole bunch of other people that are from random areas, having more people that are within their cohort already and just kind of adding another individual to do the shots might not be the most terrible idea. Better yet, if there's a nurse or someone that works within the retirement home or something that can give the shots, even better, you're kind of already part of their cohort, so it further reduces that risk of transmission. Staff and patient safety, obviously screening. So if anybody's feeling sick, under the weather, either making sure that they have a COVID negative test in place, or have them isolate for the period of time and then come in afterwards. Physical distancing, hand sanitizer, robust cleaning procedures. We should be all pretty used to this over the last few months. Technology, the more of this stuff that you can do online via apps, websites, you name it, have them punch in as much data as they possibly can, do all the screening, fill out the forms and that kind of thing. And even doing a digital signature is going to be so much better overall for just preventing, papers and other things that people can touch as they're inside of the clinic. So further reducing that risk of transmission. PPE, all patients in masks, plastic barriers, staff, masks, and eye protection. Staff for gloves, really these are only necessary when you're administering the intranasal influenza vaccine, because you're possibly going to become more in contact with their mucosal linings and stuff like that. So it's more the gloves are there to protect you from the patient, but aren't 100% necessary, just proper hand hygiene and such in that respect. And of course, if there's any emergencies or anything like that, you have to have access to the full gowns, gloves, everything in that sense. Some of my learning so far. So yeah, like I said, I did about 120 shots over the last couple of days. There's a lot of people that it's their first time either coming out to get a flu vaccine, or it's been years since they've gotten one. So these ones we need to be really diligent with and be mindful of them, making sure that you're kind of having them hang out for the full 15 minutes before they run off, and also just kind of giving them the proper rundown and spiel on all the info. Gloves are becoming increasingly scarce now, so it's becoming more the new mask issue as well. Glove quality seems to be diminishing. I had an entire box where there was just a number of little tiny holes throughout. So being mindful of that, if you're putting on gloves, just give them a quick double check. Most are okay, but some definitely might be kind of going to that lower quality as they're trying to ramp up production. Most common questions I got: is the flu vaccine different this year compared to previous years? And is there anything in it for COVID at all? Those are going to be two questions that you're going to get. Essentially, no, the vaccine is the same. It is 4 different strains of the 4 viruses that are always there per se, but there isn't anything special in it for COVID at all. Be really mindful about explaining adverse events. So a lot of people, when I would say like flu-like symptoms, and maybe you'd have like a runny nose, a headache, that sort of thing the following day, really got up in arms and saying, well, I can't go to work, I can't do that, because obviously a lot of people are having to do screeners and stuff before going to work. And technically, yes, if they are having any of those symptoms, they shouldn't, and they should be mindful of that and protecting themselves and their colleagues at work and such. So maybe if they do experiencing it, having the alternatives, well, maybe you can ask to work remotely that day or what have you. But a majority of people are not experiencing any symptoms whatsoever. And the biggest thing that people are complaining about is a sore arm. So just being mindful in how you kind of approach that and have that conversation, you might get a lot of people kind of coming back at you and not liking the sounds of potential side effects in that respect of it. Okay. Double up on your signage for wearing masks, and I'd even recommend having someone at the front door. Every person that walks into that into your building or wherever your clinic is telling people to put on masks. A lot of people needed a reminder, and a lot of people weren't wearing masks or wearing them properly. So just making sure that is very clear that you want them in masks to not only protect you, but also to protect everybody else that's going to be coming in and out of your clinic potentially. People are scared. There's a lot of questions and just a lot of fears as to the unknowns. What is this going on? Their mental health. So you're probably going to be doing not only flu shots, but also maybe a little other counseling and empathizing and stuff like that. So being mindful of that and being prepared for it, that, yeah, people are scared. They don't know what to do. They may be angry, nervous, frustrated, you name it. But just be mindful of that. And then finally, my hands are raw, dry, cracked, and bleeding. So start moisturizing now if you can. Find something that has a humectant in it, glycerin, urea. Aloe vera is also another one that's kind of considered, but I don't find it is as effective. Generally, glycerin and urea-based products are a little bit more greasy, but they work like a hot dam and can certainly help your hands heal up a lot quicker and also keep them protected in between, your various flu clinics and just with all the hand washing that we need to do. So some final notes, because I'm sure you'll get this. Current vaccine status. There is some talk that Pfizer might have a vaccine out in the States maybe in November. They're talking about applying for emergency approval and such like that. However, of course, it is being highly politicized in the US with the election and Trump wanting to take credit for it and blah, blah, blah. So I'm kind of doubtful that we'll actually get it punched out as well. There's been a couple of trials that have actually had to be put on pause due to adverse effects of people that got the vaccines, including some neurological side effects and such. So the vaccines, I mean, there's a lot up in the air right now. They're trying to push things through at a rapid rate, but we also need to be mindful of taking our time and doing it right and not making sure that we're not causing a whole bunch of harm to people. My prediction really between clinical trials, ramping up manufacturing and distribution, we're looking at about probably 8 to 12 months before we have something that's actually accessible by the public. And even then it's going to be questionable. And of course, bleach and hydroxychloroquine still don't work. So yeah, just avoid that. Final conclusions. Obviously, patients with diabetes are at a high risk of complications. Kind of a no-brainer there. We did definitely cover that. The influenza vaccine, in my opinion, is something that can be beneficial for this population and other populations that are high at risk, as well as those like us, healthcare providers, that have a high risk of transmission to others. So they should be getting it, we should be getting it, and definitely being a push in that regard of it. Benefit in working age and healthy populations. There might be. Overall, I think there's still a lot more data that needs to come out in that respect of things. It's kind of a little bit more of a controversial area, if you will. There is the idea of the herd immunity and stuff like that. However, I don't think any year we've really reached a high enough level of the flu vaccine to actually get herd immunity. Plus, there's also that the vaccine is different every single year. So whether we get a good hit or not is always kind of questionable. I know in previous years the vaccine wasn't a good match, and ultimately our influenza seasons were much worse than what they were previously and such. So the herd immunity thing is a kind of a tough argument in that respect, but the risk overall is quite minimal, and you might be protecting others. So I think that's kind of my route that I go and I talk to patients about it with it, is that you might get a benefit, you might be protecting others, and if anything else, you're not really going to get any harms from it overall. So definitely still something that I would recommend to that population, but the focus should be on the high risk groups for sure. With COVID, still highly recommended, reducing burden on our healthcare system, but the big focus is on safety for yourself and patients. So that's pretty much it, guys. Hope that kind of gave some perspective. I know this is kind of I always find like a no-brainer topic in a sense, and I think it should be in that respect, but Like I said, hopefully you got something out of this, and hopefully makes your flu clinics a little bit more manageable, and at least some of the questions that you're going to get up coming up and such like that. So I'll take some questions now, and I think in particular I had the first question on the Guillain-Barré syndrome. Um, I mean, Guillain-Barré is, I guess, if in the sense, if you just wanted to touch on it, it is a potential risk. It is a very, very rare side effect and risk, if ever at all. I've never seen anybody develop it, and I've never had any other fellow colleagues that have worked with anybody that's really developed it. I mean, it's an overall, it's one of those things that we should counsel on, we should talk about it. Um, but it is a very, very rare side effect. And I think the more and more data that we get around the influenza vaccine and the more and more seasons we do, it's further becoming more rare in that respect. Um, but nonetheless, something you need to be mindful of and still talk about. But the chance of you probably dealing with it or seeing it, I would say, are almost none.
So I'm just going to jump in here. If you have any questions, feel free to type them in the Q&A box. It should be a little button at the bottom of your screen. Some folks have already sent in some. Use the Q&A box. So if you have any, feel free to type in. We have about 10 plus-ish minutes to answer any questions. Just wait for some of those to populate in. Someone was asking in the chat. Someone was asking, is there evidence to show that Daniel, that like one of the most common concerns of someone getting the flu shot is that they will it then gives them the flu shot. They feel like they got it and then they got sick because they got it. There's evidence to show that yeah, you could still get the flu even if you got the flu shot, but it just wouldn't be as severe as it would have been otherwise.
Yeah, so very interesting data around that aspect of it. I always hear it of people, I'm sure we've all heard the story of, I got the flu shot and I still got either the day afterwards or something like that. Like I got extremely sick and I still got the flu anyways. So a couple of points around that is that first and foremost, the flu vaccine isn't 100% effective. Again, it all depends on, how closely we're matched the predicted viruses or the inactivated vaccines are to what actually the virus is that's circulating. So there's that aspect. So it's not 100% in that sense. And even then, I would still say it's maybe, I think the last number I saw was like 70% effective, even if we do get a pretty close match. So being mindful of that as well. After you get the flu vaccine, it takes about 2 weeks for your body to fully ramp up a response. So if you somehow happen to contract influenza in that time, you still very much could get the full blown flu, and as well even after that 2 week point, you could still get the full blown flu. So it is that possibility within that first 2 week period. And for the people that get the flu vaccine and then like the next day they get full blown flu like symptoms and they can't go to work, they may have picked up the flu and it just happens to be coincidence that they got the vaccine and then got sick right afterwards. They just happened to come in contact with somebody. And that's just an unfortunate reality, but it's the flu vaccine, it's inactivated. It causes, yes, flu-like symptoms, but they are going to be very mild in nature, and there's no way you shouldn't have to be missing work because of getting the vaccine, if you will. So that's just a couple of points on that in that respect. As well, what we seem to see is that people who get the flu vaccine multiple years in a row seem to develop a greater level of protection. So it's almost like it's similar viruses every year. There is changes and such, but your body still might have that adaptive immunity years and years later. And for later season or later year viruses that come out, an influenza vaccine you got 6 years ago might possibly provide some protection. But again, we don't have much robust evidence in that area, but there might seem to be that trend as well.
Great. There's a question in there. They'd love to hear your spiel on pneumococcal vaccination as well as HEP.
Okay, so on the pneumococcal vaccine, I definitely recommend it. I know here in Alberta, generally with our patients that have diabetes, we get them to get Pneumovax 23 prior to 65, and then after 65, they get another dose of it, kind of a booster, if you will. most of the layman population generally just needs the Pneumovax 23 after they're 65 years old. Prevnar 13, the evidence on this one is quite interesting because, particularly here in Canada, as kids, we tend to get a series of basically the Prevnar 7. I can't remember exactly the numbers, but essentially people got the Prevnar vaccine as a kid, so they really don't need a booster of the Prevnar 13 later on in life. Again, that's maybe a different recommendation for your high risk population, so patients with diabetes. Maybe Pneumovax and Prevnar 13 could be recommended just to kind of give them a full protection and just to give them that full, robust immune response. In terms of Hep B, yeah, hepatitis B is standard vaccination. Those ones generally aren't covered. Some public health clinics might provide coverage for them, but certainly is something to consider and provide as an option to patients if they want to get it. Generally, I recommend just getting the Twinrix, and then you're covered for Hep A and Hep B, the 3-dose series. And once you get those all done, you're hopefully all good to go for life there afterwards.
Okay, thanks. There's a question here. So for people who are allergic to the vaccine due to an allergy to gentamicin or neomycin that are used to keep bacteria from growing during the production and storage of the products, would it be safe to take the nasal active form?
That is a great question. I would have to honestly it's going to vary person to person and kind of what exactly the reaction is. I would have to do a little bit more of a deeper dive onto the evidence to kind of come up with a good formulated answer for you on that one. But I certainly can look into that and provide that information to Grace, and then that can be posted somewhere up for you guys.
Yeah, I'll just make a note of that. So what we're going to do is there'll be a timed right discussion for this presentation. We'll put the PDF, the PDF version of the slides up there as well, but it's also a discussion group for any questions that come from this presentation, anything you want to discuss further. And yeah, if Daniel has the answer to that question, I can post it in there for folks. So I'm not seeing any other questions. I will we'll advance to the next slide, Dan, and if there's other questions, because we do still have some time, we can come back to them, but I'll just promote some of our, so we have an upcoming webinar, the latest advances in pediatric care for the diabetes educator, will be on Thursday, November 12th at 12 p.m. And actually we just confirmed this morning that we'll have some webinars, so November 17th at noon and November 18th at noon. Those two presentations will be done by two of our professional section award winners. So the Young Scientist of the Year and the Lifetime Achievement Award winner will be each giving a presentation. Those to register for any of those presentations, you can do so by registering on Time Right in the same place you registered for today's presentation. And we'll just go one further. All of our webinars that we do for healthcare professionals are free. They're done free of charge. But if you're interested in, if you found value in today's presentation or any other presentations we've done this year, you might be interested in becoming a professional member with Diabetes Canada. So the website is www.diabetes.ca/healthcareproviders/professional membership. Lots of benefits from there. You get access to more groups on Time Right. We do educational events. You get access to the Canadian Journal of Diabetes. Sorry, that's my insulin pump going off. The Canadian Journal of Diabetes, as well as the Diabetes Communicator. Lots of great reasons to become a professional member. So if you found today's presentation useful, I recommend you become a professional member. And we'll go to the next slide. Diabetes Canada could use your supports now more than ever. So again, if you found today's presentation useful, we'd like to consider potentially making a donation to Diabetes Canada at www.diabetes.ca/donate. So I'm not seeing any other questions come in. Daniel, any final thoughts?
No, I apologize for the audio issues there, and hopefully it all comes in clear with the recording and stuff like that. But yeah, great to provide my info and stuff like that to people. Hope you enjoyed it.
All right, so thanks, Daniel, so much for providing today's presentation. Of Someone just asked if you get a certificate of attendance. If you want to email professional.membership@diabetes.ca, we can send you a certificate of attendance for today's presentation. Just a certificate, not accredited or anything like that, but we can give you a certificate. All right, thanks for joining us, and have a great day.
Awesome. Thanks, guys.